So what I'm going to do in the next 15-20 minutes is giving you an overview of how we assess the mitral valve. There are a lot of things that we do when we assess the mitral valve. The first thing, of course, is to define whether or not we are dealing with severe mitral regurgitation. I'm not going to go into the details of this because this would be an entire talk on this assessment. Just to tell you that this assessment is complicated, it's difficult, and it needs to be done by a combination of several items that you will acquire during your echo session. And particularly if you want to define severe aortic regurgitation, you will look for specific sign of severity, supportive signs, and you should always have quantitative measures. But you should not only rely on these quantitative measures because they have pitfalls, drawbacks, and they are very useful, but sometimes when they are in the border zone, like moderate to severe, you cannot make a decision only based on them. So one of the most important things that you should rely on is the size of the vena contracta. It's simple. You can have this assessment easily by transthoracic or transesophageal echo, and the threshold number is 7 millimeters. You could also look at the systolic flow reversal in the pulmonary vein, but I don't use that in daily clinical practice as a means to assess the severity. The presence of a prominent flail, youngsters are always looking at color. I'm looking at grayscale images because all the information is already located in grayscale imaging. And I think that if you see a prominent fail, you know that you have something which is severe. And then I quantify the mitral regurgitation using different types of methods, usually the PISA method. And I just would like to remind you that the threshold numbers for defining severe MR is 60 mL of regurgitant volume and 40 millimeters square of regurgitant orifice area. So this being said, I was thinking I was more or less going to concentrate on how to assess valve repairability. This is immediately along the questions that were asked to the previous speaker. So the assessment of repairability is something which is very important. You know that mitral regurgitation is due to dysfunction of the mitral valve. That dysfunction is caused by lesions, and of course these lesions have an etiology. There is an etiopathogenic mechanism at play here. But if you only concentrate on etiology, which is us cardiologists did for a long period of time, or on lesions usually, this translates into trashing the valve because when you look at these lesions, they're sometimes ugly and they don't tell you anything about how to repair the valve. To be able to repair the valve, you need to understand the dysfunction, and if you know how the dysfunction is occurring, and the dysfunction is lack of coaptation, and the goal of repair is to restoring coaptation, then you can design techniques that are appropriate to restore that coaptation, even if the valve still looks ugly at the end of the operation. As long as it's competent and opens well, you've done the job correctly. And you know that Alain Carpentier has divided the types of dysfunction into 3 different types. The type 1s, in which in the operating room he could find no abnormalities in valve movement. The type 2s in which he found that there was some excess leaflet motion on both valves, on one of the 2 valves, or part of one valve, and then the type 3, which at that time in the operating room when he designed that was only for restrictive leaflet motion in the presence of rheumatic valve disease, and that was the type 3A. And then now you know that we have a second type that more or less was found out thanks to dynamic imaging like echocardiography, and which is the type 3B of functional mitral regurgitation. So this classification has an impact on repairability. And once you evaluate the patient before the operation, this is probably the most important thing to do, particularly if you want to tackle asymptomatic patient. The valve should be repairable. You will not replace a valve in an asymptomatic patient. And you see that the type 2s here, called floppy by the Mayo Clinic people, are repairable in 90% of the cases, and that was in 1999, so it should be close to 98% of the cases right now. Then you have all the other ones, the non-floppy ones are the rheumatic ones. You see that you can have some degree, some repairability in these patients. Probably 2/3 of them can be repaired. And then your ischemic functional, in principle, they're all repairable, but sometimes it's not really a good idea to make a repair, and mitral valve replacement in some cases might be a very good option. You see that The durability, which is shown here as 5-year survival, is excellent when you repair floppy valves. It's a bit less when you repair rheumatic valves. And of course, you have the burden of CAD and left ventricular dysfunction in the patients with ischemic MR. So not all this attrition here is due to the mitral regurgitation itself, but also due to the underlying disease, of course. So to make that assessment, we use a valve analysis. That's an old slide. Initially, the surgeon has his direct vision, and we were thought to have the echo vision, which was quite different from the direct vision, but this is completely changed with 3D echo, and I will show you a lot of examples of 3D echo because I think this is the way to go today. And this leads to a similar valve analysis. Of course, since we did not have the same vision, we need to have a common language, which is, of course, essential all the time, but today with the 3D echo, it's probably more easy than it was at that time. You can do the assessment by transthoracic. Preoperatively, we very rarely send the patients to TE. The TE is done on the table, on the operating table. The TE is very accurate into defining mechanism and assessing repairability. You know the anatomy of the mitral valve. I'm not going to go into the details again. I suppose you've seen that in the previous session. Just a note that if you look at transthoracic echo, everything is shifted left to right. So this is your view in the operating room with the left atrial appendage on your left. But when we look at the echo at the mitral valve from the transthoracic point of view, we don't look from the left atrium, from the left ventricle. So the left atrial appendage is on our right rather than on our left, and therefore A1P1 is on the right and A3P3 is on the left. So it's something that should be well understood by surgeons when they're looking at transthoracic echo so that you don't be confusing a P3 prolapse or a P1 prolapse. With transesophageal echo, the two views are quite similar, with the only exception that the echo view is tilted 90 degrees to the left, but is exactly the same. So posterior commissure is on the top, anterior commissure is on the bottom. You have the anterior leaflet on your left and the posterior leaflet on your right, and you can usually see the 3 scallops of the posterior leaflet. The examination should always start from a retroesophageal view, and there are 3 different levels at which you can cut the mitral valve. The highest level will cut across A1 and P1, and this is the place where you see the aortic root, or at least the left ventricular outflow tract. Then you go down into the esophagus and you're losing the aorta. At that time, you have 2 large leaflets, A2, P2, and then you push down again, going to the stomachal junction, and then you have 2 small leaflets, A3 and P3. This is another way of showing that. Just an example live. You see here we're very high up. We see the aortic valve. So this is A1 and this is P1. And this view should always be taken, although the valves look small. Here was the pathology. That was an abscess on A1. Could of course have been missed if we didn't do that's cut so high in the esophagus. Then we push the probe down. You don't see the aortic valve anymore. Then you have P2 and A2. So you see these 2 valves, and then you will push down again towards the stomachal junction, and you will see 2 small scallops. You see here you have a very small annulus, and you have 2 small scallops, and you have A3 and P3. Then you're still at 0 degrees, so you don't, even if you have a monoplane probe and nothing more, you can still have a beautiful view of the valve in the short axis view from the stomachal view, and you have, as I indicated, the posterior leaflet on your right and the anterior leaflet on your left. Then there are 2 other views that need to be acquired using multiplane imaging. One is between 45 and 90 degrees, and it's called the bicommissural view. That's a very important view. And the second one is around 120 degrees, and it will show you all the leaflets. Depending on the rotation of the probe, you can move from one commissure to the other, and I think your echocardiographer should make that to have an idea where the prolapse are located. This is the bicommissural view, so that's a view where you see the left atrial appendage. Usually you see the circ artery located here. So this is P1, P3 is on the back there. And in between, it's not P2 because the valve is a little bit curvilinear, so you're cutting across A2. And if you have a prolapse there of P2, it will overcap A2, and very nicely you can make the diagnosis. And this is the 120-degree view. Here it's at the level of A2, P2. But if you move your probe counterclockwise, you will move to the anterior commissure, and if you do so clockwise, you will move to the posterior commissure, so you can have a sweeping through the valve from one commissure to the other and see all the segments. I think that the major improvement in echocardiography is now in 3D echo. And now you have the surgical view, but moving. So that's a major advantage, and you can see a lot of detail. So now we are located in the left atrium. You have the anterior leaflet on top, and you have the small posterior leaflet on the bottom. And I will show you several different examples. This is a large posterior vegetation with leaflet perforation. Of course, you can see that vegetation and the perforation also with 2D echo, but it's so easy to see that with 3D echo, you have all the anatomical details that you can see here with that vegetation and the perforation. So it's really something which is visual, and you don't need to reconstruct that in your mind anymore. Things that are quite difficult to see with 2D echocardiography, this is an anterior commissural prolapse with a ruptured cord. You see the prolapse very well of this anterior commissure. Of course, you can see it as well with 2D, but it's really difficult not to tell it's a P1 prolapse rather than a commissural prolapse. Clearly, 3D is really helpful in defining commissural prolapses. Also, for posterior prolapses, the 3D is very useful, probably more for those who are doing interventional cardiology. It's clearly a P2 prolapse with several ruptured cords, but for the first time with echocardiography, we are able to see the width of the prolapse. It was very difficult to have that information before. You see that now it's a very localized small prolapse as compared to that very large posterior prolapse. If you have to clip that, the first one clip will probably suffice, but here you will probably need to have several ones. So this is for the first time in information that we can get, and that will probably change our practice in the future. Here is in a 2 prolapse. You see the ruptured cord here, and then you can beautifully see the prolapse there. And I think I still have an example of a posterior commissural prolapse, which you can see here. Of course, you can also see it with 2D, but it's much more complicated to do so. Bileaflet prolapse usually requires a reconstruction of the different cut planes so that you can make sure which are the segments which are prolapsing, because in this Barlow disease you can clearly see here the P2 prolapse. But if I tell you, and I will not show it, but if I tell you that all the segments were prolapsing when you do the reconstructions in 2D from that 3D information, you would never guess that, because your eyes is immediately attracted by the huge posterior P2 prolapse. So in this case, everything was prolapsing, so probably working on the papillary muscle and so on would be useful. And then you have the other types, the type 3, this is the rheumatic valve, and I think it's important to use then the 2D reconstructions. You can clearly see the huge coaptation gap, so it's very severe regurgitation. And then you can see also that there is a severe leaflet restriction in motion, both in systole and diastole. You can even make the calculation of the mitral valve area using that technology. And finally, this is a kind of a functional mitral regurgitation in a patient with eclipsed mitral regurgitation. It was going on and off, but very severe. And you can see the difference with the previous case is that here the anterior leaflet is moving perfectly normally. So this is not a rheumatic disease compared to the other one. So if we look at the comparison between 2D and 3D, we gain about 5% or 5 to 10% accuracy. When using 3D compared to 2D. So now there's other things that you need to do before the operation. The first is to look whether the annulus is dilated. This is relatively easy to do. We use the 120-degree view, where you can measure the anterior-posterior diameter of the annulus from one side to the other, and you can also measure the length of the anterior leaflet, which should more or less correspond to the size of the annulus at about a 30% difference. This can be easily done in that view. You can make both measurements from that view, make that calculation, and tell whether or not the annulus is dilated. I've been asked to talk very briefly about the risk of SAM. This is something which is, of course, a very important complication of mitral valve repair. Fortunately, it starts to be rarer than it was before. And you can see already in this example a typical situation. You have a patient in which you have that movement, anterior movement of the mitral valve after weaning from bypass, and you can see already one of the characteristics of this. This is a very small annulus, so the ring was probably too small. You see that we have a very tall posterior leaflet, so this small ring is bringing that posterior leaflet into the LVOT, and finally we have a narrow mitral aortic angle, which is also pushing the coaptation in the LVOT. So we have three of the most important factors that lead to SAM postoperatively: a small ring, a tall posterior leaflet, and a narrow mitral aortic angle. And of course this leads to a gradient in the left ventricle and of course to mitral regurgitation. It hasn't been confused with this. This is immediately upon not even weaning from bypass. The heart is starting to beat, is completely empty, and you have a SAM which is more or less a pseudo-SAM. And of course it leads also to mitral regurgitation and a gradient in the left ventricle, but if you fill the heart and stop the inotropes, these ones can disappear and do not need to do anything on these, with usually very good prognosis. So these are the predisposing factors for SAM that you can assess preoperatively: excess of tissue, narrow mitral aortic angle, a non-dilated left ventricle, of course, and a hypertrophied basal septum. The last thing I'm going to touch about, which was asked, is mitral annular calcification. This can also complicate your job quite significantly. There are two types of calcification that can be seen in those type of pathology, and the group of Alain Carpentier and his fellows are dividing the prolapses into fibroelastic deficiency, which is occurring late in life and is associated with ruptured cords, with the Barlow disease. This is funny because in that Barlow disease here you have a ruptured cord and you don't have it here in the fibroelastic deficiency, but I took these two examples from that publication. And this is important because in Barlow disease, usually the calcifications are relatively superficial and then can be easily resected en bloc without having too much disruption or no disruption into the AV groove, which is not always the case in fibroelastic deficiency, in which the calcifications are often invading the muscle, and then if you have to get rid of those calcifications, you will be left with a lot of tissue loss at the level of the AV junction. So in Barlow disease, it's relatively to decalcify it. It's much more complicated to do decalcified in patients with fibroelastic deficiency. This is the location of these calcification in Barlow disease and fibroelastic deficiency. You see that they are more often located at the level of P1, P2, and P3, with a predominant incidence at the level of P2. And if you look at the freedom from cardiac events after the operation, clearly if you have to decalcify in Barlow disease, usually you have quite a significantly good prognosis. But if you do the same in fibroelastic deficiency, there's a lot of recurrence of mitral regurgitation and some early death due to ventricular dehiscence. So this is my last slide. I think that for this indication, of course, you can do it with echo, but I think there is a future for assessing these patients with CT, because with CT you can pretty much well delineate not only the location and extent of the calcification all along the mitral annulus, but also look at the invasion of these calcification into the muscle. Here is an example of a patient with a very small calcification. It's almost circumferential, but it does not invade the muscle at all, and is probably much more easy to resect if it was invading the posterior part of the ventricular muscle. So I've tried to illustrate the fact that we can assess the pathology. This has an implication for the repairability of the valve. 3D is certainly helpful in defining all the different aspects of pathology. Is much more easy to use than 2D, although sometimes you have to go back to 2D reconstructions. And finally, I've just touched upon factors that are affecting the risk of SAM and the role of calcifications and how you should tackle them with echocardiography or with CT. Thank you for your attention.